Thank you. It's a pleasure to have a chance to present and talk with all of you today, and to share this session as well with Anita. So I'm going to try to move quickly as I do so. It was nice. I think I met most of you when you visited Nemours back in early March, and I remember thinking this would be the last in-person presentations that any of us would be seeing for a while, and I had no idea how true those words really were. But I'm glad to be able to share some work with you today. This is kind of a combination of work that I talk about quite often about our psychosocial assessment tool, or the PAT, but also to share with you a grant that we're just beginning in terms of the implementation of the PAT. So I will start by just giving some basic, sorry, I keep losing my screen here, some basic information about family psychosocial risk screening and how it can enhance clinical care. I will tell you a little bit about the psychosocial assessment tool, and then, as I mentioned, talk about our implementation study, which is to implement the PAT across 18 pediatric cancer programs around the United States. This work rests on a social ecological approach to child health. I'm sure you've all seen some variant of this model, initially coming from the developmental psychologist Urie Bronfenbrenner, who talked about the importance of understanding children and child development in the context of broader social realms. And specifically, in the innermost circle, we have the child, the family, illnesses, medical conditions, and the immediate family, surrounded by concentric circles of increasingly more distal influence on the child and family. So if this were drawn realistically, there would be bidirectional arrows all over this this diagram, but that wouldn't look too attractive, so we keep it simpler. When we do screening, we're looking, to identify essentially hotspots around the social ecology. What are the areas of risk for an individual child or family that require further assessment and intervention in order to provide comprehensive evidence-based care? Another model that's very integral to this work is called the Pediatric Psychosocial Preventative Health Model, or the triple PHM. And this is basically a public health model, a pyramid with, at the base of the pyramid, universal family risk. So these are families that certainly have some reactions and challenges as they cope with a pediatric health condition, but they're basically resilient families. And the implications in terms of psychosocial care in a pediatric health setting is to provide support, psychoeducation, and continue to monitor and screen for higher levels of risk. The middle tier of the pyramid are targeted families, or families where there is some identifiable family distress or risk factors, and we want to provide interventions specific to those symptoms. As a psychologist, I know that there's a lot of interventions that can be provided at that level if we can identify families early on and deliver that care. At the tip of the pyramid are the clinical families, or the families that in some ways are the easiest to recognize and the most difficult to treat, and where you need to have a behavioral health specialist, where you have to intensify services, and where you really have to address the impact on medical treatment. So we've done some research over the years trying to figure out how to implement screening and how to do so systematically, and thinking about what are the advantages of systematic screening? Why is it important? In terms of benefits to patients, families, and organizations, it can change the course of psychosocial and medical outcomes to understand what a family brings to the situation as they come into a hospital setting. It can also be part of crisis management, if you will, because early intervention can reduce or prevent later problems. We hope that it facilitates the process of providing the right intervention at the right time for families. And importantly, we also hope that it promotes health equity by assuring that all families get the care matched to their needs. We know that in reality, there's a lot of situations in which families are getting care based on the extent to which they come to the attention of the healthcare staff. And the idea of systematic screening is to screen everybody, regardless of how they may appear or look to various people on the healthcare team. In terms of providers, we think about this as being consistent with the psychosocial standards. We have psychosocial standards of care in pediatric cancer, in a couple of other disease groups as well. And how to deliver that care, it can be a challenging problem, but screening is a good way to start that process. Screening also has the potential to make our jobs as healthcare providers easier through early identification of risk and the prevention of problems that may escalate later. We also believe that it can improve the effectiveness and efficiency of practice, and it can be the first step in building a relationship with families. So let me tell you a little bit about the PAT. The PAT is a brief parent report screener of psychosocial risk. It's been validated now in English and Spanish. The all literacy version is at a fourth grade reading level. We have research going on in many places around the world on the PAT for many, many years now, actually. And we've had translations into quite a few languages, although not all of those are necessarily validated translations. We've also adapted it for use in other English-speaking countries, and we collect data through our website, and we're actually getting ready to do a big analysis of all the web-based data, which is close to 13,000 or so administrations. It is being used at 68 sites around the United States, and some places have multiple departments using the PAT. So the PAT has been out there and being used most frequently in pediatric cancer, but also across a wide variety of other conditions. When you complete the PAT, it's scored, and the scores map onto the PPP-HM so that you have families' risk scores falling into the universal, the targeted, or the clinical and treatment areas. We also have clinically relevant items, the red flags that are called out separately and reported in the report that's generated. So on the left on this slide are all the domains that we assess with the PAT. And this is where we started 2 decades ago, really, in terms of asking what are all the things that are important to know about a child and family in terms of psychosocial risk. Those domains on the left then map onto 7 subscales of the PAT, and those 7 subscales total up to a total score. So what you see there are a variety of types of risks, more socioeconomic, structural resources that a family has, and then psychosocial family problems, social support, the problems of children and siblings, and then also beliefs. Just going over briefly a couple of studies that we did on the PAT. This was actually a study for what we did at CHOP. And we, at this time, wanted to know, could we screen families shortly after a child was diagnosed with cancer? This was in the pre-electronic era, let's just say it that way. And we were able to successfully screen families, this was in pediatric cancer, within 48 hours in almost all of the 88% of the families. And then once screened, we were able to score and communicate the results within 1 to 2 days as well. Again, this showed that you could do this quickly at diagnosis. Whether or not it's important to do it at diagnosis is something that we've thought more about over time. And again, the scoring and the communication can now be much quicker. This was the same study at CHOP. We rotated months of screening with the PAT in pediatric cancer with months where we didn't screen with the PAT, and we looked at psychosocial risks in the medical record and in the social work notes. And what we found was that families that were in the months where they were screened with the PAT had more services than months where they weren't screened with the PAT. And that controlling for time in the hospital and the amount of universal services provided, that families who were at the upper tiers of the pyramid received more targeted and clinical services and had more social work activity. So we saw this as facilitating the delivery of care that was matched to the family's need. We also found that that screening was important in order to get those risks documented in the medical record. So the current version of the PAT is technically the third version. Both the second and third are quite similar. The changes we made in the third was that we succeeded in lowering the reading level. We made the PAT more generic so that it could be used in a broader range of patients, and we enhanced the items for children under the age of 2 and added some new items about aggression, suicidality, crime and abuse, mental health treatment, and child use of medication for behavior. And we also moved to a web-based administration. I think this slide is interesting and important because it shows on the left the PAT, the English version of the PAT, and on the right, the Spanish version of the PAT. And what you see there is the blue area for the English-speaking families is 62% of the sample fell into the universal area, if you will, the base of the pyramid. That's a finding that we've found over and over again across different patient groups and different international settings. And on the right, the people that filled out the PAT in Spanish had about 35% in the lowest risk group. And what you see is a higher proportion of the families that completed the PAT in Spanish falling into the targeted or the clinical range. So I think that's an important finding, and is one that we hope to continue to understand and impact more as we go forward with implementation. So it's also good news that we have found that we are able to predict clinical cases on the PAT using the stress thermometer, a measure of acute stress, and also child behavior scale, strengths and difficulties questionnaire, and that we have the scale scores are good predictors of caseness on those measures. So let me turn now to implementation science. I think you've had a recent lecture with Renad Badas on implementation science. So I won't dwell on this, but we are we now have something to implement, right? We have the PAT, and we want to move that into implementation. The first step for doing that is that we conducted a study to identify barriers and facilitate care of screening with the PAT. We asked, this was a study of sites that were using the PAT and participated in qualitative interviews. We asked, are there patients who should always be screened? How can screening impact care? What resources would you need? Who champions screening, etc. From the qualitative data analysis, we identified an overarching theme that screening is important because it facilitates clinical care. And those sub-themes were things like it optimizes psychosocial care, that implementation and how to do the screening was important, thinking through those issues, that screening actually helped engage families in care, and that screening facilitated the use of clinical pathways in psychosocial care delivery. We also conducted an implementation pilot to implement the PAT in the southeastern United States. This again was in pediatric cancer. We did a one-day in-person training held in Orlando, and brought in people from 16 participants from 12 centers. And we followed that training with monthly consultation calls for 6 months or so, and evaluated the implementation. We were very pleased that 9 of the 12 centers were able to implement the PAT successfully after that training. And those that didn't were small centers that actually didn't have new patients during the duration of the project. So one of the insights we learned from this is that there's some centers that have very small populations and very small patient groups. The PAT was administered most frequently by social workers in the site, sometimes by psychologists, and then in other cases by nurses, navigators, or child life specialists. We were pleased that people indicated that the PAT was very or extremely helpful in their work. Most centers were providing feedback to families about their PAT scores, usually within 24 hours or within up to a week. The people perceived, they were very enthusiastic about the benefits of screening at the outset, and mostly remained positive throughout the project. We found that some of the challenges that were anticipated at the outset were things like reimbursement, some technical issues, and how to integrate screening into the EHR. Okay, so let me tell you a little bit about the grant that we've just received from the American Cancer Society. This is a grant that was written collaboratively with Lamia Barakat from CHOP, with Janet Dietrich from Penn as a qualitative consultant, and our coordinators at Nemours and CHOP, as well as our oncology colleague, Eric Sandler at Nemours in Jacksonville. So I've already told you about the PAT as a validated brief parent report screener in English and Spanish. I didn't tell you about another study that we did where we showed that the PAT was being used in about 29% of cancer programs around the country, but we realized that although we know people are using it, we don't know a lot about how they're actually using it and how it's been implemented. So this is a slide you may have seen already, but this is basically, we are down here now in the, not sure if you can see my arrow or not, but we have a practice of interest. We have the PAT, and we're flowing down along here, and we're going to say that we have evidence for effectiveness, and we're going to use mixed methods to understand further. We're going to design or augment implementation strategies, and then we're going to test those strategies. The implementation framework that we selected for this project was Interactive Systems Framework by Abe Wandersman and his colleagues, which has three levels of the framework. The first being what's called prevention synthesis and translation, and that is to make sure that the approach that you're trying to implement is accessible, user-friendly, and important, and has utility in the environment. The second phase is the prevention support system, and that is the delivery, if you will, of the tools to assure that the evidence-based intervention is implemented. And then the prevention delivery system is the third component of this approach, and that is to sustain the implementation approach. So here are the aims of the grant. The first one is to refine our implementation strategies, and I'll say a little bit more about those in a minute. but using semi-structured interviews with a diverse team of stakeholders, including parent advocates, multidisciplinary providers, representatives of national professional organizations, and healthcare industry leaders. We've just completed those interviews, and we are analyzing the data for that now, which we will use to refine the two strategies there in the second aim that we're going to compare in an implementation of the PAT in English and Spanish using a cluster randomized trial at 18 sites around the country. The third aim is to develop and disseminate a web-based implementation toolkit using the results from the trial and input from our stakeholder team, who we would go back to for further assistance. So what we did was we selected implementation strategies from the expert recommendations for implementing change review. The citation for that is below on that slide. This is a frequently referenced document for picking implementation strategies. We're going to randomize, we're going to stratify by size of childhood cancer programs based on number of new patients per year. We'll have 3 sizes. And we're also going to have 3 cohorts, meaning that each of 6 groups, each of 3 groups with 6 centers in it will participate in 1 year. And the first year will start next January in 2021. So we selected the sites based on their capacity, our perception of their capacity to implement the PAT. And what I mean by that is we conducted a previous study and we collected data on the psychosocial staff available at pediatric cancer programs around the country. So we picked the places and invited sites to participate based on having psychosocial staff that were at least at the median for their size nationally. All sites are going to receive training in the form of a professionally prepared webinar that we're working on now. And then there are 2 conditions. One is the training only, and the second condition is called TIER, which stands for Implementation Enhanced Resources, training plus implementation enhanced resources. And they will identify a champion at their site and also participate in monthly consultation calls. And we'll be looking at outcomes at the patient, the family, the provider, and institutional levels. So we're just beginning to gear up for that. These are the sites. We're picking, as I mentioned, places based on psychosocial resources, staffing, based on size, and then also based on centers that have the potential to accrue a significant number of Spanish-speaking families in their screening efforts. So in preparing for implementation, each site will complete an implementation plan, which is essentially their contract with us as the investigators to evaluate the success of the screening implementation. So at the end of the training, each center will tell us who will do the screening, what staff members will do the screening, who will be screened, and we have, as I've mentioned, we have a variety of size centers in this study. So in a large center, you may want to focus in on one subgroup of families. In a small center, you may be more inclined to try to get all people. But whatever group of families are selected to be screened, we're wanting all families in that group to be screened. They'll also decide how they want to use the PAT scores in their clinical practice. We obviously provide some guidance in the webinar about how they can do this. They also talk about institutional considerations, how this will work in your particular setting. We recognize that doing screening in different settings will require different types of considerations and accommodations, and including things like, can it be integrated into the EHR, can it be billed, etc. And then we, as part of the study, go through a detailed session with the sites in terms of the data collection and how the data will be collected and transmitted to us for analysis. So here is the flow chart. Again, randomized to either training or training plus implementation, expanded resources over the 1-year period. The data collection ongoing over the course of 12 months, and then for the tier group, interspersing the monthly consultation calls in addition to the surveys. So that's all that I had for today. I just wanted to sort of give a quick overview of the PAT and this new study that we're just getting ready to launch. So I think I may have a few minutes, if Jeannie agrees, a few minutes for questions before turning this over to Anita.
Yes, absolutely.
Thanks, Anne. This is Theta Ong from Seattle. I just had a question about how you were choosing. You mentioned outcomes in different levels for families, providers, institutions, et cetera. And I guess do you have a primary outcome for studies like this when you're trying to direct the arms, or when you're constructing those aims? And are those outcomes influenced by the mixed methods that you're doing?
Mm-hmm. Yeah, so we have a number of outcomes, and the primary one is really, did you screen the families that you said you would screen? So a count, essentially, of the number of families screened over the number of anticipated number of families who would become available in that month. And then looking also in terms of Spanish-speaking families, and looking at that as well. And then we have measures of, we actually have some measures of burnout and engagement, staff engagement, center engagement with families. And also have some exploratory aims around financial, health, economic outcomes potentially.
As a follow-up question to that, in terms of the outcomes, are you comparing them to families who don't receive that intervention, or just showing like change pre-implementation and post?
We're not collecting any data on, if I'm understanding your question correctly, we're actually not collecting any data on family outcomes per se. The outcome is just whether or not the screening was completed.
Mm-hmm. Okay.
Does that answer your question?
Yeah.
Thank
you. And then unrelatedly, I was curious because we're a couple of our departments here use the PAT 2.0, I think at this point. Have you had successes in looking at other populations outside of cancer? I think our CF clinic uses it here, as well as our liver transplant team. But the other, I was just curious because you had kind of alluded to this, any use in like an acute care setting. Being a hospitalist, just curious, because I know that tool is very broad. It's just a little bit harder to do when we have patients that are coming in like for 24 hours or just a short stay.
I can't, was that Anita?
Yeah, this is Anita,
Yeah,
sorry.
okay. I can't see your faces right now. Yeah, so Cincinnati is a super user of the PAT, with Anna Pai there, who has done adaptations for different transplant groups, right? So that's she's been actively involved in that, and also was a colleague on an adaptation and a study that we did in bone marrow transplant recently. The PAT it's been used in a lot of different settings. I don't think I'd have to look into this. I don't think that it's been used in the sort of population that I think you're talking about as a hospitalist. I think it would be relevant, however, particularly for families with, I think perhaps the bind is if you're not going to have an ongoing connection or relationship with family. If it's a one-time admission, it might be a little bit trickier, but I think it would still be very helpful in terms of understanding the risks that this family has and the future for the planning of their care.
Thanks.
Any other questions for Anne?
Yeah, it's Chris. Thanks a lot for that. One quick question, maybe it's be the final, then we'll transition. What have you learned in terms of implementing the PAT that is applicable, you think, for other, I'm going to call this a tool / technology that could be ramped up to an entire health system? That's often a strategy that learning health system scientists use, is that they'll develop an algorithm, they'll develop a tool, but then there's a need to ramp it up. And I'm curious what you think you've learned that would be applicable sort of more broadly across tools and technologies that would be relevant to learning health systems.
Yeah, well, we think that that having a champion or multiple champions is probably very important. We'll find out more about how that functions in the course of this study. I think helping make the case for how this can make everybody's job easier and how it can benefit families is important. I'm thinking about some of the things that we've learned from the interviews that we've done. I think thinking about how to communicate that, how to fan that information out, is very important. And I think how to show people that it makes a difference in their care. So it's sort of a balance, perhaps of those factors.
Terrific, thanks.
Okay, thank you so much, Anne. And this is a great segue. I'm glad we were able to have Anita on today. And I think, Anita, you have the control. Is that? Yeah, we're seeing your slides.
Yeah, you can see my slides. Do I need to go to presenter view?
Enlarge, maybe that would be good.
Is that better?
I think it disappeared. Do other people see it, or is it just mine? No, yeah, I think it disappeared. So maybe go back to where you were.
Anita, I found that it was kind of underneath the Hollywood Squares pictures. If I clicked down at the bottom of the screen, it would come back.
Oh, I think I'm on my web, so I don't know if it's a little bit different. I can see my slides, but I was trying to go to presenter view. Can you see that now or no?
Yes, we can see it now.
Okay, perfect. So yeah, thanks, Jeannie. I think it was awesome to present after Anne, although there's work that I need to live towards, so I'm really excited So briefly, my project was inpatient screening for parental adversity and resilience. And as a reminder, I am a pediatric hospitalist, so we were thinking about some of Anne's work, but also ACEs related work and how we could implement in an acute care setting. So some of the early background work that I'll discuss was funded by some of these earlier grants, as in addition to the K-12. And just in case folks are not familiar with adverse childhood experiences, I'll just quickly define that here. So this was a questionnaire asking adults about specific experiences that included abuse, neglect, and what they categorized as household dysfunction. And so this was defined as any child living with a parent or caregiver that suffered either from mental illness, had an incarcerated relative, witnessing domestic violence or substance use or abuse, or parental divorce. And as a reminder, these were questions that were actually asked of adults about their past childhood experiences. And what they found in a seminal study by Folletti et al. Was that there's a dose-response relationship. So the number of exposures you had was associated with increased rates of both physical and mental health comorbidities, such as cardiovascular disease, depression, diabetes, etc. And so I'll just highlight that ACEs are a static measure, meaning that once you have an ACE, you can't get rid of it, which is a measurement issue if we're trying to improve outcomes. And then a high number of ACEs is thought to increase your stress levels, known as toxic stress. And this we know is damaging to development for children. And so in our early work, we looked at actually the parental ACEs of parents of hospitalized children. So we surveyed about 1,700 parents of hospitalized children, and 1,320 responded. 36% reported no ACEs, 45% reported 1 to 3 ACEs, and 19% of this 1,320 reported 4 or more ACEs. And we deemed this the high risk group because we know in the adult studies that an ACE score of 4 or higher was associated with the comorbidities I mentioned earlier. And so the quick summary of this is that there was a high prevalence of parental ACEs on the hospitalized cohort. This was just at Children's or Cincinnati Children's. This is higher than the national average. So generally about 12% of families have 4 or more ACEs in national studies. And so resilience is really the flip of that, and that is the ability to cope with and bounce back from stressors. So while ACEs are static, this is something that's modifiable and that we could measure and track change over time. And so with that same cohort of the 1,300 parents, we also looked at their brief resilience scale scores. So that was a survey, it was about 6 questions. This is a histogram of those responses. So a low score here represented low resilience, and a high score here represented high resilience. And you'll see here the average was about 3.9. So the majority of parents self-reported that they were resilient. And so there's a high prevalence of this as well. So we also looked at both parental ACEs and resilience and how they affected hospital outcomes after discharge. So we looked at parental coping.
Anita, this is Chris. Because,
yeah.
Hold on 1 second. On my screen, it's frozen. It's frozen for other people.
No,
Well,
I think you might be having a connectivity because your webcam too is kind of flashing in and out.
Okay. All right. Thank you. Sorry to interrupt. Go ahead, Anita.
No worries, I can send those slides too, but everyone else can see, we're good. Can you guys see and hear?
Yeah,
Yes.
we're good.
Okay, all right, perfect. So we looked at parental coping difficulty, which was measured 2 weeks after hospital discharge. It's a validated tool. And we found that parents with more ACEs had higher difficulty coping after discharge, and parents with high resilience scores actually had less coping difficulty after discharge. So thinking about what we could potentially do in this space. We also looked at the intergenerational effect, so specifically how parental ACEs affected child healthcare utilization. And so we define this as returning to the ED, urgent care, or hospital readmission within 30 days of discharge from that index hospitalization. So we found that parents with 4 or more ACEs actually had children with 1.7 times higher odds of reutilization, even after adjusting for a number of covariates. In the final models, the resilience scores were not significantly associated with reutilization. So just as a quick summary, both parental ACEs and resilience were common in the hospital setting, and then they both affected hospital outcomes after discharge. So this leads me to my aims as we studied this in a randomized control trial that I'll get into in a second in a study, but we weren't routinely screening for these psychosocial factors in the inpatient setting yet. So that leads me to the K aims I had. So for aim 1, we wanted to determine which characteristics, whether it be patient demographics, place-based factors, supported identification of parents with either the high ACEs or low resilience. And then aim 2 was adapting these existing screening tools, so the ACE questionnaire, to co-design a family-friendly screening process that effectively identifies these parents. And the reason we thought about this is because the ACE was meant to be a population level measure. It was never meant to be a screening tool itself. So to boil down aim 1, which is the focus of today, what I'll talk about today, is can we clinically predict which parents might actually have high ACEs or low resilience without actually asking them? And so we used that original data set I mentioned, and this was part of the hospital to homes outcome study. So this was an RCT through my division, and the primary study here was to study the effectiveness of a nurse home visit, whether it be in person or over the phone versus the standard of care, 46 hours after hospital discharge. And the primary outcome here for that was reutilization. So as I mentioned, we surveyed 1,700 parents that had both completed the ACE and resilience surveys. And then we also had an H2O survey that included a number of variables that I'll get into briefly that was within this data set. So this is quite a bit. I'm not going to go too far into detail here. I'm just going to highlight a couple of the variables we had within the H2O data set that are less commonly used. So one was primary care access, which measured the ability of the family to travel to the doctor, see the doctor for routine or sick care, or get help on advice on weekends. And then financial or social strain was the parent's ability or the family's ability to make ends meet, pay rent, mortgage, or utilities, move in with others due to finances, or the ability to borrow money if needed, in addition to home ownership or parental marital status. So our analysis here, I had some PhD support here, but we created an elastic net regression model. And for those similar to me prior to me working on this, this is a great model to use when you have a lot of different variables. So you can think about the H2O survey in addition to ACEs and resilience, and you're not sure which variables are the most useful. And there's a lot of correlation between parameters. And that for those that might be more familiar with this, this is a combination of the lasso and ridge regression. So in essence, what we did is we created multiple models where we had predictors to identify our outcome of interest. So we had the outcome of interest was either a parent with high ACE, low resilience, or the combination of both. So in that first model, we included variables that we would find in the electronic health record. So this included patient age, sex, or race or ethnicity, just to name a few. And then in the second model, we actually tied this to place-based factors, and these are tied to a patient's home address, which is available on the EHR. And so I'm not going to go too far in depth here, but the place-based factors that we used were the area deprivation index, crime, the modified food retail index, and green space. And so the reason we chose these is we were trying to identify the family's context. So what are some assets in the community and what are some risks that might help us better predict which families or which parents have high ACE or low resilience. And so when we actually got into the data, we found out that the crime database was a little bit too sparse for the data that we required because it was limited to the greater Cincinnati area, and our study trial ended up going a little bit, excuse me, beyond that. So we ended up only using the 3 place-based factors here. Excuse me. And then the final model was including all of the Model 2 components in addition to those H2O variables that I alluded to earlier. And so our results, we had the 1,787 parent-child dyads, and as I mentioned, 1,320 had completed the ACE questionnaire, and 1,272 actually had a complete data set, so including both questionnaires in addition to the additional demographics and H2O variables that we required. So in that population of the 1,272, we actually dichotomized here to the low ACE group, which was 773 individuals, and then the high ACE group. So this is anyone with 4 or more ACEs, and that was 499. And so just briefly, these groups were similar in terms of sex and age and race, but you'll see that there's significant differences in insurance, the deprivation index, as well as income, and then a couple other variables here. They were also different in terms of education and strain. And so I'm going to walk you through these results because I know it's a lot. So on the x-axis here, we have the area under the curve, or the AUCs. I'll caveat, we have to modify this image. I know the x-axis is a little bit skewed here, so it only ranges from 0.45 to, I think, 0.6, a little bit higher than 0.6. And then the y-axis has all the models, and our outcomes of interest are at the top here. So the primary one of the outcomes was the high ACE group, the middle was the low resilience, and then the third is the combination of the two. So the model 0 is just our null model, meaning if we just use all these used and predicted by chance, what we would get. And so that's always at the 0.5 mark. And then model 1, as a reminder, is the EHR. Model 2 included the area-based measures, and model 3 included the H2O variables as well. So you'll see all of the models predicted better than chance, which is good. However, and then you can see for the high ACE group and the low resilience group, model 3 really performed the best out of all 3. And then in the final model, you can see actually, or sorry, not the final model, but the one that combined both outcomes, model 2 was actually the best predictor. So I'm a little bit of a visual person, so I'll just highlight what did it mean. So the ROC curve, this is just for resilience, and you'll see each of the different models in the different colors here. Really, while we were better than chance, we weren't really clinically helpful. So our ideal ROC curve would look something like this, and you can see we weren't really much better than predicting better than chance, even though it showed a little improvement there. So while the models did predict better than the null model, these are relatively clinically insignificant predictions. So for example, for our resilience piece, it was predicting all parents to be resilient because the majority were. And so this actually led us to our AIM2 pretty nicely and unexpectedly though, but it just led us to that we probably need to ask parents directly, because even with the analysis we did a little bit more of a sensitivity analysis, which I won't get into here. We still didn't find any great way to predict either outcome. And so AIM2 was to adapt existing screening tools to co-design a family-friendly screening process that effectively identifies these parents. And so we used both the ACE and resilience questionnaires in addition to the strain that I highlighted earlier, but we also use a social determinants questionnaire. And the reason behind this is there was an independent project going on in our unit of interest where they actually already were asking about 5 questions related to transportation, housing, and other social determinants. So we thought we would get feedback on all of these. And so our methods were to use cognitive interviewing, which I know Chris had alluded to earlier. But this is to study how the population understands, mentally processes, and responds to survey questions. And a qualitative researcher helped us to develop an interview guide based on those tools. And that guide was used to provide parent and give us parent feedback on those tools. So from that information, we were hoping to create a prototypal screening tool and then test it using some quality improvement measures. So we used, in terms of our recruitment, a community engaged approach. So we partnered with a local nonprofit, Healthy Homes Block by Block, to recruit parents from Price Hill. And so Price Hill is a neighborhood near Cincinnati Children's that's predominantly low income and has disproportionately high hospitalization rates compared to other neighborhoods in Cincinnati. And so we prioritized parents that had children that had either been to the ED or had a hospital admission. And I won't get too much into the details here because I know I'm a little bit limited on time. But this was kind of, if we were taking at one of the sample questions, what were the approaches we used to get information on how the population of interest really understands and processes these questions. So these are just some of the preliminary themes and results we identified. So parents wanted information on or gave us feedback on the location of the screening, how to administer the screening, whether it be electronic or not, and with whom, as well as justifying the need for screening, and then some minor screening tool adjustments. So at this point, we've interviewed about 15 parents, and we're in the process of completing the coding and filling into that theme bucket. We're hoping to interview just a few more till we reach thematic saturation, and then modify the current tools based on that feedback. We did have a quality improvement team that launched in March, and then COVID unfortunately shut that down. So we're hoping in the fall we'll be able to kind of relaunch at a smaller scale based on accessibility and PPE. So we plan to test the tool using PDSA cycles with staff and parents. And then as we're developing the tool, we intend to have a response algorithm developed. So if we do translate to like an electronic health record form, that we would be able to easily translate some of the steps here, but we would also be intervening on these positive responses as we're screening. So I just wanted to say a quick thank you to my mentorship team. This would not have been possible without them. And I'll stop for any questions. Sorry, I didn't mean to stop sharing there.
Anita, Stephanie, this is great. I'm curious in the background information that it looks like is in press right now. You mentioned sort of coping and adjusting for a number of covariates. How are you guys thinking about like child illness, comorbidities that the child has, and acuity of that hospitalization in sort of the bigger picture of this work?
Yeah, that's a great question. So in that original study, it was a gamut of children. So they could have had like medical complexity or other comorbidities, although somewhat limited because the RCT didn't allow for anyone that was already getting home health visits, because that would change the results of the primary study. So I haven't taken a deeper dive into how we're going to address that, but with the new tool, we've included both social determinants and adversity and resilience questions, but also questions about stress related to other, just hospitalization itself. So I think that's going to come through in that piece, because we know that jumping right into ACEs or something that's sensitive might be a little bit more difficult. So we're trying to take a step back and just identify stressors across the board. So I think this will look a little bit different for that chronic care population, and we actually have a separate team that works with children with medical complexity. So I think there's going to be learnings that are separate, because those families have been to the hospital quite a bit than some of our short one-time admissions.
Anita, Chris here. Sorry, I've been popping in and out. I'm not sure what's going on, but we're short of time, and I just need to say, great presentation, great work. I'd be happy to, if you wanted to send any material over my way, I'd be happy to give you some comments. I'm going to make two, but I had several others. The two quick comments are, I've never been a fan of ACEs because it's such an extreme set of indicators on adversity. One of the things now we're working on, we have in the HERO trial, HERO registry, we've got close to 20,000 people now who initially talked about adversity around exposure to the virus, and now they're talking about financial strain. We're talking about healthcare workers really thinking about how the pandemic is affecting them. So the first issue is, as you begin to mature this work, I would encourage you to more broadly conceptualize adversity than ACEs. And then the second is, be careful with the word resilience. Resilience is a very complicated concept, and you're not either resilient or not. There's resiliency in your life that you may find in your community, in your family, and in individual reserves that you may have. So that measure you've used, I know a lot of people have used it, but it is a pretty weak measure. And I think I would again think you to think about clearly articulating what you are measuring. I wouldn't just call it resilience because it looks neat, but it's not actually the resilience of the person or the family. And then second, again, to think more broadly about resilience. And I think maybe one of the reasons why your AUCs were so low was because the lack of truly conceptualizing and then measuring the full spectrum of the measures. But very exciting work, really quite exciting.
Yeah, thanks for that feedback. I agree with you on terms of ACEs. I think it's informative to an extent, but I've kind of broadened into what I call social adversities, because I think there's, family level that the ACE questionnaire really highlights, but then there's community level that we need to touch on that incorporates the social determinants. And then with resilience, I agree. I think it was one of the measures that we could use that was brief enough to use in an inpatient setting, but I've since then delved into Ann Maston's work on the kind of broad range of what resilience could be. And I think it's really hard to define, except the one key thing we keep finding is that social support is just the critical piece, that if families at least have one or multiple other people, that really can flip how they respond to stress. So I appreciate that, but I think that's helpful. And I think that's helpful for providers to understand like what supports they do and don't have.
Do we have time for another question? Or?
Terrific responses.
Go ahead, Don.
So that was great. I have, I don't know if it's a question or not. First of all, I just have to say, I like the idea of resilience. And if I'm not mistaken, there was a woman from Cincinnati, I don't know how many years ago now, presented at the NERSA T32 conference on resilience. And I thought her construct was actually quite sophisticated and resonated with me. She included faith which turned out to be a prime determinant of people's resilience, which I think is very interesting, especially in these times. So I don't know, Chris and I can hash that out at some point, but I think the concept's actually quite useful. The questions I have are two-part. First is, in retrospect, maybe you could have predicted that asking people directly was going to be better than trying to predict from various data sources. And the other question, there's a lot going on Price Hill. I speak to Peter a lot and Rob and so forth. It seems like the community is saturated with all these studies and efforts to help. What's that like? Are they resilient enough to deal with the onslaught of well-intentioned people doing research on them?
I think because of folks that work with Peter, so Carly Riley is one of the intensivists that really brought the community engaged partnership together. I think they are saturated to an extent, so we're mindful of how many participants and how many surveys that population is getting. We try to stray away from that a little bit. So there are a couple parents from that group in itself, but we also tried to use like the snowball technique. So using parents we've interviewed to identify other parents that were not as heavily surveyed. I think it's informative to an extent, so I think that's helpful. But we've tried to be a little bit mindful of making sure we're not using the same partners, because it's a lot of the same researchers that we kind of cross-pollinate with.
Yeah, this just reminds me, Peter would appreciate this, I'm sure, because he's so invested in improvement. Do you have a sense, if you're sitting in Price Hill and you're interested in all the stuff going on, do all these things fit into a driver diagram that actually is trying to improve something that people at Price Hill care about? Is this part of that, or is it true, but unrelated to an overall driver diagram for better health of Price Hill?
I think it is overlapping, but so pre this work, I was involved in a grant where we sat with Price Hill community members and a few other academic researchers to identify what their interests were. And so we were trying to align both what our research interests were, but also use kind of the community-based participatory research to identify what their interests were. So I think there are key drivers that I'm not as familiar with that are leading and laddering up to what their interests are. Does that answer your question?
Yeah, I mean, it's not really a question, just I think it's a conundrum we always have when we have communities who are underserved and with great need, and a lot of people are trying to help them, and having a unified picture of what the logic model is or the driver diagram to make a difference in their health and well-being is sometimes tricky.
Yeah, I agree.
Thank you, everyone, especially for staying a couple extra minutes. And just thank you so much again to Anne and Anita. And this topic is really timely. So I hope everyone is kind of being taking care of themselves and their own psychosocial well-being. So we'll speak to you all in a couple of weeks. Thank you so much.
Thanks, guys.
Bye-bye.
Nice job, Anita.
Thank you.